Hello, everyone, and welcome to the first webinar of 2024 for HealthLinks. Just letting everyone in from the waiting room. Our conversation today is on psychological preparedness for emergencies in the workplace. And just as a reminder, this is the first webinar of 2024 for us in the HealthLinks webinar series. We're going to go ahead and get started. So thanks everyone for joining us today. We always start with a land acknowledgement. So as we gather in this virtual space, we honor and acknowledge that the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations. Further, we acknowledge the 48 contemporary tribal nations historically tied to the lands that comprise what is now called Colorado. Acknowledging that we live in the homelands of Indigenous peoples recognizes the original stewards of these lands and their legacies. With this land acknowledgement, we celebrate the many contributions of Native peoples to the fields of medicine, mathematics, government and military service, arts, literature, engineering, and more. We also recognize the sophisticated and intricate knowledge systems Indigenous people have developed in relationship to their lands. We recognize and affirm the ties these nations have to their traditional homelands and the many Indigenous people who thrive in this place alive and strong. We also acknowledge the painful history of ill treatment and forced removal that has had a profoundly negative impact on Native nations. We respect the many diverse Indigenous peoples still connected to this land. We honor them and thank the Indigenous ancestors of this place. The University of Colorado pledges to provide educational opportunities for Native students, faculty, and staff, and advance our mission to understand the history and contemporary lives of Native peoples. My name is David Shapiro. I am the Senior Manager of Programs and Partnerships at the Center for Health, Work, and Environment, and I manage our HealthLinks Public Health Outreach Program. My pronouns are he, him. I am a white male in my mid to late 40s. I have dark brown curly hair, and today I'm wearing a teal blue button-down shirt and dark gray glasses. I have a clean-shaven face as well. HealthLinks is a public health outreach program, and we champion health and safety at work. We're based at the Center for Health, Work, and Environment at the Colorado School of Public Health, which is one of 10 national centers of excellence for total worker health, funded by the Centers for Disease Control and NIOSH, the National Institute for Occupational Safety and Health. And we are also one of 18 research centers, the Mountain and Plains Education and Resource Center. A few things for you all to note before we get started today. All participants are on mute throughout the duration of the presentation. If you want to use the chat function right now and tell us where you're joining us from, we'd love to hear it. It's terrific to see all the places around the country and around the world that our participants join us from on our webinars. So go ahead and use the chat and tell us where you're logging in from today. And that being said, we want you to use the chat in case there's any technical issues for today's webinar. If you end up having a question for me or the other presenters today, we ask that you put those in the Q&A box because our colleagues or your other participants may have the same question and then they can vote on them. Closed captions are available for those of you that need them using the Zoom closed caption functioning. Our webinar is being recorded and we will share a link to the recording in the days following up after this event. There is a survey at the end of this webinar. We know how important it is for those of you claiming continuing education credits, and it's the survey function that allows us to issue those. So make sure you stay till the end of the event so that the survey link pops up and you're able to complete that survey. We will have a link to the survey available at the end of the webinar as well. So biggest thing there is tell us where you're from in chat and use the Q&A if you have any questions that come up. I do want to also mention that the views expressed in this webinar are the views of us as speakers. They are not expressly the views of the University of Colorado or the Center for Health, Work, and Environment. So today's agenda, we'll have a keynote presentation on psychological preparedness for emergencies in the workplace. We have a discussion to provide some context with some subject matter experts that are doing this work directly in the field. And then we'll have time for question and answer time with all of our speakers. And we're hoping that at the end of this webinar, you'll be able to understand what psychological preparedness generally means and how it applies to the workplace, that hopefully you can develop a strategy for personal psychological preparedness in your workplace, and that you're acquiring some skills to support other employees in the workplace in preparing for a crisis. Because this is the first webinar of 2024, we want to highlight the great work that we've accomplished in 2023. There's some statistics here that I just want to share with you. We had 7 webinars in 2023 with almost 4,000 individuals in attendance. That's a 31% increase from 2022. Over 90% of you, when you attended our webinars in 2023, completed that evaluation survey, which we really appreciate. It provides valuable feedback to us as a team, and it also helps with those continuing education credits. People rated our webinars highly in 2023, and we had participants from 50 states and 23 countries, which we're just really grateful for and excited about that all of you are able to join us from so many diverse places around our country and around the globe. So it's my honor to introduce our keynote speaker today, Courtney Welton-Mitchell. Dr. Welton-Mitchell is an assistant professor in the Department of Environmental and Occupational Health at the Colorado School of Public Health. I should say former. She's now transitioned into a new role, where she directs the certificate, or did direct the certificate in climate and disaster resilience. She is a trained social psychologist and mental health clinician specializing in traumatic stress. And in addition to her domestic clinical mental health work, she worked for several years in complex humanitarian crises, first as a humanitarian aid worker and later as a trainer and intervention researcher. In recent years, Dr. Welton-Mitchell has co-created, implemented, and evaluated mental health integrated climate adaptation and disaster preparedness interventions for earthquake, flood, fire, and conflict-affected communities in Nepal, India, Haiti, Malaysia, Lebanon, and Australia. She recently completed a CDC NIOSH-funded intervention research project focused on psychological preparedness for the public school workforce in Colorado and designed a similar training working in collaboration with frontline healthcare workers in Ukraine. Dr. Welton-Mitchell, it's an honor to have you here with us today. I'm going to go ahead and turn the screen sharing over to you.
Thank you so much, David. I really appreciate the opportunity, and I look forward to our discussion. So I hope you all can see those slides. I am going to go ahead and jump in here because there's a lot of content that I'm hoping to cover in about 20 minutes so that we have time for Q&A and further discussion. So I just want to share a little bit about some of what I've been thinking about in collaboration with many colleagues in the US and elsewhere around the construct of psychological preparedness and really incorporating that in some of what perhaps many of you are already doing in the workplace around emergency preparedness or disaster preparedness and response. So we know that emergencies in the workplace can certainly happen at any time, and we can be talking about things that are human-made or natural hazards, a whole range of potential emergency scenarios. And typically we think about psychological components as secondary. We focus primarily on the physical preparedness piece. So today what we're going to do is talk a little bit about ways in which we might begin to understand how to incorporate the psychological components in the broader landscape of emergency preparedness that really typically has emphasized the physical piece. First, I just want to point out that it's a relatively new but emerging literature on psychological preparedness. And so here are just a few examples. If you just put in that as a search term, you're going to see a number of things that are coming up. Here you have some examples around COVID and psychological disaster preparedness and unmet need, knowledge, skill, competencies, psychological preparedness for nurses in disasters, a systematic review, and conceptualizing and measuring psychological preparedness for disaster. There's been a lot of discussion in recent years about standardized measures that we might use to essentially determine whether or not psychological preparedness is happening, and in order to kind of implement interventions and measure the effectiveness of those interventions. So as we move along in the slide deck, I just want to highlight that there are a number of resources that are really tremendous resources out there that look at this broader landscape around what we think about as the emergency preparedness physical component. We can see Occupational Safety and Health Administration resources. We can see FEMA resources. We have a whole range of industries: school employees, healthcare workers, construction crews, humanitarian aid workers. All industries are needing in some form or fashion to prepare for a variety of human-made and natural hazard related threats. And often we can see, we might have more complex safety and security plans for a particular context, but often we also see these succinct SOPs or other mechanisms through which we would be reminded about how to perform certain behaviors in a crisis. So you can see on this slide on the right-hand side, this is from public school infrastructure. In an emergency, take action, hold, secure, lockdown, evacuate, shelter in place. We have other run, hide, fight models, call 911, how to perform certain steps to ensure that emergency services are on site in a timely manner, and things of that nature. So again, there is this historical focus on what to do, what we can think of as physical preparedness. But what about the psychological processes that can get in the way of performing these required actions in a crisis? And this is part of why psychological preparedness matters, why it's so important. It expands on the traditional notion of disaster preparedness by incorporating awareness of psychological processes, physiological reactions to threat, and importantly, the practice of adaptive coping skills. So when we think about psychological preparedness, we can think about easily adapting it and incorporating it into existing preparedness activities. So just to look a little bit at, there's a lot more content than we can cover in the context of this webinar, but on the back of the slide deck, I'll have a link to a resource page where you can find a complete manual that's publicly available on the work that we've done in the public schools, integrating psychological preparedness into emergency preparedness, as well as other resources and forthcoming publications. So in brief, when we think about psychological preparedness, one of the things that we need to focus on is an awareness of some of the common responses to threat at the psychological and physiological level. So we might think about under an immediate threat scenario, an increase or change in breathing, heart rate, blood pressure, sweating, things that we might typically describe as a fight or flight or fight or flee response. We can also think in terms of the brain processes, the neurological infrastructure. An alert person's brain typically has moderate amounts of chemical messengers that lead our prefrontal cortex to take charge and perform high-level thinking. But under stress, when we have chemical signals that are flooding the brain, this can actually change and, in fact, often impair our ability to make thoughtful, reflective decisions in the midst of a crisis. So stress arousal can make us, for example, miss cues or details in our environment. It can make it difficult to pay attention to more than one thing at a time. We may have tunnel vision, so we might see one narrow thing quite clearly, but not see or register, pay attention to, or encode other things. We may not hear well. We may hear sounds, but we may not be processing the sounds effectively. And again, in some cases, some of us, we may be in a position where we're frozen. We feel unable to react or move. We may run. We may just instinctively run, but not think about where we're running or thoughtfully why we're running. So when we have this anxiety response, there are some things that are potentially beneficial. In some cases, that tunnel vision can be helpful. We can also have heightened sensory perceptions. But I think in sum total, when we think about needing to actually thoughtfully and rapidly review complex information in the midst of a crisis, it is probably more often the case than not that our stress response is actually getting in the way of our ability to perform the behaviors that we want, interfering with our ability to think clearly, making it difficult for us to process complex information, and impairing our ability, again, and importantly, to engage in thoughtful decision making. Because often we're trying to process complex information that we will want to utilize in order to determine the appropriate outcomes. So in some of the work that I've done along with colleagues in a variety of different settings, including working with the public school workforce, one of the things that we do is we try to walk people through this process where we say, okay, there is some variability in stress response. Maybe, we don't want you to necessarily think of a traumatic event that we're asking you to recall. You want to voluntarily think about things that you're comfortable recalling around a time when you maybe felt you were under stress, or there might have been an adrenaline rush. I often use an example of when I was driving and a car ran a stop sign and just blew right through that stop sign right in front of me. I didn't get in an accident, but I had an immediate stress response to that situation. So when we think about reflecting on our own stress responses, we can use worksheets like this, for example, with our workforce, and we can ask people to say, are any of these things familiar to you? Have you had situations where your heart was racing, you had trouble thinking clearly, you felt frozen, increased breathing or different breathing patterns? And maybe there's other things not on the worksheet that people can identify. So this part of psychological preparedness, this first piece is a little bit of psychoeducation about what happens in our body, and then asking people to reflect on their own responses. So why we want to ask people to reflect on their own responses is because we want them to then move into, okay, let's learn some skills about how we can regain control of these responses. So there are lots of different ways of thinking about coping skills, but when we're talking about an immediate threat scenario, what we really want to focus on are coping skills that we can deploy in the immediate moment that only take a few seconds. So in a lot of cases, we think about there's kind of a constellation of coping skills that are around grounding exercises. So we think about trying to ground ourselves in the moment in order to override our stress response. It's a tool for managing stress that helps to connect you with the presence and kind of short circuit some of the stress response that's taking place. This can enable your body, it can enable you to essentially be back in control. It doesn't necessarily completely diminish your stress response, but it can enable you to override it to some extent. So there are a wide range of things that we can think about in terms of grounding exercises. They can include things like thoughtful count-based breathing, reminder note cards, touch, taste, images, smells, shortcuts for remembering behaviors we want to perform. So typically what I've done when working with individuals around this process of psychological preparedness is I've next asked them to look at grounding options and a coping plan and select things that might resonate for them. Because for all of us, we're going to have things that resonate and things that don't resonate. And then on the back of this worksheet that you don't see represented on the slide is there anything that's not on this worksheet that you've used or that you might like to use that you think could be useful? And in the context of training on psychological preparedness, we have individuals in the training share with one another some of the things that they feel like may be effective for them or have been effective for them. So it's really about a suite of options and enabling people to feel empowered to pick things that they feel like they can imagine themselves actually utilizing in order to regain control of their stress response and ground themselves in an immediate threat scenario. Some of the easiest to deploy are things like something with a very strong taste, something with a pungent odor or very strong smell, something like splashing cold water or touching cold water, and then these kind of intentional breathing exercises. So just to recap, we know that stress arousal can interfere with our ability to think clearly. It can make it difficult to process complex information, which is critical in the midst of a crisis, because everything that we learn in terms of emergency and disaster preparedness, it's meant to provide a framework or scaffolding, but it can't be prescriptive. For example, when we're talking about a lockdown situation in a school, there are certain conditions under which a teacher would choose to evacuate that classroom and other conditions under which they would choose to stay put. And that involves them acquiring and processing new information as the crisis unfolds. So stress arousal can impair thoughtful decision making, and things that are immediate coping skills like grounding techniques that can be deployed within just a few seconds in the midst of a crisis can help us to regain control of our stress response. And the purpose of this is so we can perform the necessary actions, that physical preparedness component, engage in the kind of actions we would choose to engage in if we were able to thoughtfully reflect on our actions instead of perhaps impulsively respond because of our stress response. So as I mentioned, we do have a website here, and this is something that I'm sure David and HealthLinks can share out on our website and elsewhere, in terms of taking you to a landing page for the particular project that I mentioned, the mental health emergency preparedness for the school workforce. On that website, you'll find some news articles. Once we have an article published that's currently under review, that will be posted there as well. You can download the full mental health integrated preparedness manual that we use for the school workforce. This is what you see on the left-hand side of the slide. And you'll see in that particular intervention manual, this is a half-day training where we have 4 modules. One is on emergency preparedness. The second is psychological preparedness. And then we also have a module on peer support and then providing feedback for emergency managers. This is employee feedback for emergency managers in terms of how to kind of co-create or share leadership for emergency preparedness. In brief, in this intervention that we did implement in 6 schools, it was a match cluster comparison. We trained almost 500 teachers and staff, and we measured a number of outcomes, including psychological preparedness after this half-day training. And in fact, the results showed that the most robust results of all the outcomes we measured were for psychological preparedness. So a brief mental health integrated emergency preparedness training can help teachers and staff to feel more psychologically prepared, in control of their responses in a crisis. And these results that we received from this particular training are consistent with a growing literature that emphasizes the potential benefits of training in psychological preparedness. And again, when we think about what that involves, it's identification of risk, understanding of likely psychological and physiological responses, and proactive planning around coping, grounding, and other exercises so that we can regain control of our stress response. So again, here's that landing page where you can download these resources. And I encourage you to visit the broader literature with a search term, psychological preparedness. Well, you'll see a whole suite of emerging journal articles, but also resources, including resources that can be practically applied depending on the context and across a wide variety of industries. So thank you so much. And I look forward to further discussion on this topic.
Thank you so much, Dr. Welton Mitchell. I'm going to regain control of the presentation here and introduce our next speakers. But before I do, I just wanted to ask, the assessments that you mentioned in your presentation, are those included in the manuals or the resources that you were talking about?
We actually do have comprehensive assessment tools that we can post separately on the website, but that aren't included the full suite of assessment tools in the manual, but we're happy to share those on the website as well.
Thank you so much. And so for everyone to understand, we are recording this webinar. We will share the slide deck as well as the resources afterward, including hopefully these additional assessments that Dr. Welton Mitchell mentioned. Everyone will have access to those resources in the next few days. So it's my honor to introduce our next speaker today, Corey Warden. Corey has designed, implemented, and led safety, health, environmental, emergency management, and training programs for over 20 years. He is currently a safety administrator at the city of Houston, Texas, where he specializes in chemical, biological, radiological, nuclear, and explosive hazards, and threats and works with the Houston Fire, Health, and Police Department's Office of Emergency Management, and he serves as the city's ICS safety officer. Corey has published over 120 articles, presentations, podcasts, and panel discussions, and he serves and has served in multiple senior volunteer leadership roles with the American Society for Safety Professionals, the National Safety Council, and the Association for Occupational Health Professionals, and he's earned 22 major awards. Corey is a U.S. Air Force veteran. Thank you for your service, Corey, of Operation Enduring Freedom, and he has earned 10 military medals and awards. So, Corey, it's our honor to have you here today. We're going to hear from you, if you don't mind turning on your camera, and I'll start the slide deck for you.
Great, thank you. Well, I certainly appreciate the invitation. I have just a couple of remarks here, so I'll be brief and don't want to get too much time for all the other great presenters today. So this first bit here, as you can see, what I did was juxtapose the high reliability principles with the safety management system, the kinds you would find in ANSI V10 or ISO. And so the idea here is that we can take something that is kind of abstract in nature and often difficult to ascertain how to implement, and we can make it very digestible and easy to understand. So in short, if we're telling people that we're preparing for emergency situations and we want to be preoccupied with potential failure modes, then by doing an effective hazard and threat analysis, we're able to effectively do that. Same thing here is if we want to get subject matter expertise, not only for things like hazard identification and threat assessments, but also things like the ICS and the NIMS, then we needed to defer to experts. And that may not be the highest ranking person in the room. It might be somebody who has a particular level of subject matter expertise. Further on there, if we want to be able to be reluctant to simplify and not just assume that things are okay, or we have a good level of preparedness, same thing as we want to make sure that we're able to keep things effective while still reasonably safe, then we want to be able to use leading indicators so that we can effectively prepare and validate our levels of safety and preparedness. And then, of course, we want to be able to investigate any potential negative outcomes, incident analyses, fault tree, things of that nature, and being able to use that information to continue to develop resilience. So if we're able to do that, then it gets us onto a good level of preparedness to begin with. On the next slide, it's going to talk about a little more detail at the tactical level. So the thing here is that in terms of preparedness, if we're asking people to be able to respond to potential emergencies, then there's a couple things we want to make sure we're doing. Is number one, we want to make sure that we have due diligence in terms of making sure they understand how to identify the hazard and the threat, make sure they have due diligence in their expectations as far as what they're supposed to be doing to respond to it, and that they're adequately prepared to do that. And number three is make sure we've done due diligence in terms of making sure that we're watching out for them and that we're enabling them to have proper, not only preparedness, but again, resilience and sustainability. So a couple of things here, as we can see, is that, we want to make sure they understand what the hazard and threat look like and how to be able to not only identify those, but assess the risk for it. And that ties into situational awareness. As far as the actual hazard and threat control processes, what we want to be able to do is use the higher level controls first. That's one of the things we talk about a lot with disease exposure prevention, things like, especially like with pandemic level threats, is that if we minimize the number of people that are at risk to begin with, then that's much less we have to think about in terms of things like respiratory protection and contamination control and decontamination or disinfection and whatnot. So if we use things like hazard elimination is not necessarily a feasible thing to talk about there, but things like identifying the people that are expected to be in the hot zone, and then the people that aren't expected, we can simply keep them out of there and use things like isolation, quarantine, physical barriers, physical separation, ventilation, things of that nature. And so then it minimizes the number of people that have to be in the hot zone. Then from that point, we're able to provide a very real, clear assessment of what the risk is and how to control it to the best level we can. So in that case, we want to make sure that we're being empathetic. We're making sure we're not condescending or patronizing people. We want to make sure they understand what they're dealing with and how to effectively do it safely. And so in that case, you know, one of the big things there is we don't want to assume or we don't want to claim that we can control something 100%. You know, while we're not going for risk acceptance, at the same time, a lot of these emergency situations are calculated risks. So there is a point where we can control it to the best degree possible, but in order to complete the objective, there is a certain level of risk that's going to be taken on there. And so in that case, we can make sure that people have the proper, again, hazard identification, the proper hazard controls at the level they need. And then from there, we can make sure they have effective communication so they know the situational awareness, they know the real-time ongoing situation. And then from there, we're able to use those leading indicators to check these things in real time. So if something starts to go sideways, we can catch it early. Then from that point, as you can see there on the second column, there's a couple other things we can look at on the back end of that, which is going to be making sure that we're checking for employee or worker or responder perceptions, concerns, all of these things that come up in real time so that we can address that. That does two things. Is number one, it helps us to maintain effectiveness and prevent the situation from worsening, but it also provides a level of psychological support and assistance, so to speak. So in that case, we're able to make sure they understand not only what they're dealing with, but how to do it effectively, and that there are resources available to them, which are going to be things like employee assistance programs, critical incident stress debriefings, and things of that nature, so they don't feel like we're just throwing them into the fire and expecting them to be able to do everything independently and autonomously. So there is a system and a mechanism there for their support. So due diligence is basically a great way to summarize a lot of things there. Next, please. So the last thing I was going to say here is this is a model that I use a lot and when I'm talking about things like any kind of potential emergency response. And what this does is it explains how something can go from a workplace safety hazard up to a full-scale emergency response. And in some cases, it can do that relatively quickly. So as you see on the graph there, if we're talking about this in terms of frequency and severity, we have employee safety and the employee safety hazards and threats on the far right side of the diagram. And so that's at the level where we have very high frequency, meaning we deal with these sorts of things every day. You know, for example, in the case of public health, law enforcement, EMS, there's a potential workplace violence threat almost every day. That's just the reality. So we're talking about very high frequency, but we're talking about relatively low severity, meaning it may impact an individual or even a team, but it's not going to shut down the whole operation and definitely not going to shut down anything outside of that operation. So we want to be able to handle these things at that high frequency, low severity level. And that's where we get into the safety management systems and the high reliability principles and the due diligence. So the reality is if we don't handle it at that level, then the situation can potentially worsen. And that's where we get the lower frequency, but the higher severity with something like a campus safety or facility safety, or even a community safety issue. And the difference is not only are we talking about potential exposures, injuries, or illnesses to the individual or even the team, but we're talking about something that can affect either the whole facility or even the whole community. And that also increases other risks such as potential litigation, liability. So from that point, if we still don't handle it, if we're talking about something like an infection prevention issue, now we're talking about a potential outbreak or even something worse. And so that's going to become a lower frequency yet higher severity situation. And then if we still don't handle it, then we get up to the lowest frequency, but the highest severity, which is going to be a full-on emergency management situation. And the reason I say the highest severity is because not only does it affect the individual and the team, and even the community and the facility, but it can shut down everything. So we're talking about something that it can shut down a hospital, it can shut down an operation, it can shut down even a city and the economy, which we saw with 2020. So long story short there is if we're able to provide the effective preparedness, due diligence, and provide that level of redundancy and empathy and overall preparedness, then we can handle these things at the lowest level so that it ideally will not escalate. So that's kind of my bit for the day, but as always, I'm happy to be here, happy to answer any questions or talk more. So thank you all for your time.
Thank you so much, Corey. I really appreciate the models and the layers and the level at which you're describing emergency preparedness and response. I want to share with you our next panelist and speaker for today. As a reminder to everyone, if you have questions for the panelists, and we see a lot of questions coming in, feel free to use the thumbs up arrow if someone has asked a question that you'd like to be responded to in this webinar, rather than retyping it. With that being said, it's my honor to introduce our next speaker, Sabina Colligan. Sabina is the founder and CEO of EHS Transformation Consultants, leading a cutting-edge occupational health and safety consulting firm that specializes in transforming unsafe workplaces into industry benchmarks. Another Air Force veteran, thank you for your service, Sabina, and chair for the board of Global EHS Credentialing, Sabina brings discipline and leadership to her roles where she advocates for workplace safety. With a client roster that includes companies such as Netflix, Hostess, Harvard, and Twilio, Sabina is dedicated to ensuring people work in safe environments while providing organizational leaders with peace of mind. And beyond the boardroom, Sabina is a wife, a dog mom, and an avid yogi. Her life, marked by the serendipity of adoption, fuels her gratitude and desire to live untamed. Thank you, Sabina, so much for being here.
Thank you, David, for having me. So I will start this presentation off, somewhere in between Dr. Wilton Mitchell and Dr. Warden. And I'll start with the story of what got me interested in this space. I came from the Air Force. I was an emergency responder there. And in a deployed environment, we had a situation where we had these highly skilled roles that had to come together from different locations around the globe to protect these vulnerable populations or essential populations of our military personnel. And at our home bases, we had roles and responsibilities and relationships with people that we knew and that we trusted. But we ended up in a very particular situation where two regular household cleaning items were mixed in a dormitory or temporary living facility. And those two cleaning agents, which was basic chlorine or Clorox and an all-purpose ammonia cleaner, created something called chloramine gas. And in this situation, there was very little ventilation, and there were threats because we were in this deployed environment that could look like an attack on military personnel. And so you have these people, firefighters, emergency responders, or emergency management, much like Corey, individuals that were responsible for physical safety of our military personnel, the occupational health component, our medical component, all coming together for the very first time under a very high stress situation, and something that was being managed from the highest levels of our military, who are concerned that we could potentially have an attack. What ended up happening was, because we had never been together, we didn't have trust, the roles and responsibilities were different based off of the locations that we came from. It became very high stress. Some individuals shut down, or what we call stonewalled, where they were just a brick wall, couldn't get through to them. Every bit of subject matter expertise that they brought to this type of response was null and void. We couldn't get through to them. And then you had some people who their stress response was command and control, but that wasn't their role nor responsibility, which caused some infighting. Ultimately, we executed well. We were able to resolve the issue, but the psychological, the way that the folks responded was not on par with the level of subject matter expertise and training, high level training that we had provided. And so as we dug deep into that situation, we found what we see on this slide here. And what we see is a triangle. And at the bottom of the triangle, there are 3 additional triangles, which say roles, responsibility, and relationship. And I like to preface this with a definition that leadership is kindness with clarity. And so the bottom of this pyramid is leadership and clarity. And for organizational leaders, what we learned was that you have to have trust. We needed to have the relationship. People needed to know who was who and what they could do. So we ended up leaning on the relationships that we had, people that we knew, because we trusted them in that moment. In the heat of the moment, that's who you're going to, the people that you trust, the people that you know have the right information for what you need. And so the recommendation in order to get to the top of the pyramid, which is another triangle that says preparedness, is to make sure that the foundation is correct for the individuals that you are responsible for leading in these times. So making sure you have clear defined roles. Everyone knows exactly who's responsible for what. It's great to be a team member. However, it's really important to respect the subject matter expertise of the people that are responsible in their areas, even if you know how to do it. And then making sure to take those roles and responsibilities and build that relationship as a team, especially when you're coming together in these high stress situations. It is imperative. And from that foundation, you can build that preparedness. That is the responsibility as a team. Next slide. The other side is the individual. And it's important that the individual is able to have a level of awareness and be able to lead themselves. They need to be clear about what their psychological responses are and have a means of communication. So on the screen, there's kind of like a beehive of 4 recommendations for emergency response preparedness for yourself. The first is awareness. And that awareness, Dr. Wilton Mitchell did a great job in, I think, the appendix 4 that she pointed out. And that's to recognize signs of stress in yourself and the coping strategies that work for you. You have to know how you respond and how you are able to cope. Every strategy is not meant for every single person. And for the leaders in the organization, it's important that we model that healthy coping strategies. The second is a meditation. And David mentioned I'm an avid yogi. I'm also a meditation teacher. With meditation, it's important that you practice now so you can implement when you need it. Meditation is one of those practices that can be great, but in high stress without practicing it, it may not be effective. So for anyone that is expected to be in an emergency response situation at any point, I would say that anyone that works in a workplace could be, or just walking. Dr. Mitchell mentioned just somebody driving through a red or a stop sign. So practicing it now so that you are able to implement later. And then the third, Dr. Mitchell mentioned as well, as grounding exercises. So these are physical exercises that just bring you back to the present moment. Some people like to just feel their toes touching the ground or wiggling their toes to say, this is where my feet are. Another technique that you can utilize is taking an object and just focusing on that object and feeling the textures of that object, being so focused on that one particular object that's in your hand, if you have the ability. And then the fourth is taking micro breaks, scheduling those short breaks in without additional stimuli. And sometimes when we take a break, we want to check our phones, we check social media, we're checking emails, but that could actually be counterproductive to what you need to get grounded and back into the moment and reducing that stress response. So And you can incorporate all three of the other exercises into your micro break, even if it's 10 seconds, 20 seconds is all you have. Just making sure you're planning that out. If you are a person that has like an Apple Watch or the situation allows you to, you can set timers to say every hour, take a micro break, just to remind yourself where you are and ensuring that you are being a productive member and part of the solution during an emergency response. And that is all for me, David.
Terrific. Thank you so much, Sabina. I just want to remark that leave it to our psychological preparedness webinar for us to be terrifically on time. To the minute, everybody is on time today. So I really appreciate that. Sabina and Corey, will have you join us for the Q&A section if you're okay with that. Thank you. Sabina, just one question before we move into the questions, which is, could you just give us a brief definition of command and control, which are two terms you used during your presentation? We're not all familiar with that.
Oh, I am so sorry. So my military background came in. So command and control on simple terms is just having, how do I say this in layman's terms? It's so simple in my head. It's just having a level of control around a situation. So if you think about an investigative site where the police are there, they've got the caution tape, and people are being told to step back, not be in that space, that would be an example that we've probably all seen or heard of in the news or on a movie, where there's just command and control. People are where they need to be, and the scene or the area that is affected is not being impacted by outside sources.
Got it. Thank you for that description. So, HealthLinks does a lot of consulting with businesses on total worker health, and disaster and emergency preparedness sometimes come up. But we have a question about something that Corey mentioned in his presentation, which are employee assistance programs, or EAPs, and what are their roles within this context. I think one thing we've recognized in consulting with hundreds of businesses over the past few years is not every EAP is constructed the same. There are some that are really high touch and very adequate with the services they provide, and there are some that may not provide as high level of detail services. So the question is really about, is there any evidence or supporting research, or maybe I'll start with you, Dr. Welton Mitchell. How do you think EAPs, employee assistance programs, are integrated into this process? Have you thought about that at all, or have you looked into EAPs and their role within disaster preparedness, psychological preparedness, and emergency response?
Thank you. I can't really speak directly to the evidence base around this, but what I can say is, in the context of the work that myself and colleagues, including Natalie Swatka, have done in the public schools, we worked not only with safety and security, but also with the mental health staff. And one of the things that we did as part of that mental health integrated emergency preparedness model is we educated the workforce about their EAPs and what was and wasn't available. And we considered whether or not staff involved directly with EAPs might in the future be part of a cohort of trainers around the mental health integrated emergency preparedness. But in the models that we utilized, we were working with the district mental health staff. But I do think that that's absolutely something that could be reflected on across a range of industries in terms of the role of those managing the EAPs.
Corey, did you want to comment at all about how City of Houston, or you in your role, utilizes EAP, or what sort of function they play? For me, EAPs are often called in as grief response and trauma coordinators after the incident. I'm not sure if that's the role that EAPs play at City of Houston, or what is the role of the EAP in this situation for you?
Certainly, it's actually interesting because at the city, we as the safety team, we fall under risk management, which falls under human resources, which also manages the EAP. In short, what I can say is that we keep the EAP in the conversation as a resource, like was just discussed, and we use that as a matter of transparency so that our teams know that we're going to do everything we can do to keep the bad situation, what the Marines call left of bang, so your timeline, you have your preparedness, you have your incident, you have your recovery. We want to keep everything to the left of the incident itself. But for those situations that do go, to the right of the bang, then the things like the EAP and the critical incident stress debriefing and all of those resources are going to be available to them so that they have that level of support and transparency about what the situation is. So to the question as far as the efficacy, to be honest, I can't answer that right now, but I can certainly ask some questions and I can dig around and see what I can come up with. But that's kind of a summary of how we look at those resources. Thank you.
Thank you. Sabina, anything you want to add as a consultant? Do you interact with EAPs? I think we all acknowledge that, evidence, we'll have to dig into the research behind it, but more a matter of how that particular resource is utilized in your mind as an EHS consultant as well.
Absolutely. So EAPs are a part of when I'm consulting the Total Worker Health Initiative and ensuring that people have access to resources to manage their mental health, right? For the most part, but other things that cause stressors as well, like financial management, weight management, all of the things that can cause someone to not be in a good space. Can you imagine getting an eviction notice the same day that you have an emergency response? Things you're just cognitively not there the same way. And so having constant access to those types of supports, that is something that we recommend for any organization that does not have that. And outside of emergency response, we recommend that across the board.
Great. Thank you. The next question I think is a really important one, and I'm just going to read it verbatim from Mariah, I believe, is who asked it. And this comes up a lot when we're doing consulting in office spaces that aren't necessarily thinking about psychological preparedness necessarily frequently. So preparedness and safety are topics that are not often prioritized due to the perceived time commitment involved with planning and training. So what would you say to organizations that have historically not prioritized these critical topics? Would it be to hire a full-time employee that could focus on it and champion preparedness, or what other suggestions might you have? I think I'll start, Sabina, with you, if you don't mind. What would you say to a company that in the past, let's talk, maybe it's a small business, it's an office space, and they've really not talked about it at all. Where would they start? Or what kind of response would you have for them about, what's the most critical thing for them to prioritize here?
Absolutely. I had a conversation with a client about this yesterday, so the response is fresh. Identifying a risk assessment and what that looks like. So a small office space of 4 or 5 people have a significantly different response than a manufacturer that maybe has some type of chemical that could be released, right? So starting off with the risk assessment to identify what are the needs, and then from the top down, making the commitment to the resources that are necessary to fill those gaps. Whether you don't need the full-time resource, you just need a contractor that is on call 24/7 for your response needs, or incentivizing a small group of people that volunteer, and maybe they have extra pay or they have some other type of incentive to participate and be prepared for what could happen. So it doesn't always have to be hiring, but you have to identify the risk that you have and be willing to accept the risk of any gaps that you decide not to fill.
Yeah, I appreciate that. Dr. Welton Mitchell, I know your most recent project was with school districts, but I get the sense you've worked in a variety of industries on this type of work. But any thoughts from you about, here's an organization or an industry or a company that's really not given this much thought. I like the idea of risk analysis or assessment starting first. That sounds like a good baseline, but any other comments you want to add on to what Sabina said?
I would just say, I've worked throughout my career with humanitarian aid organizations, and I think that we see the evolution in the last 10, 15 years, where even the relatively small to medium-sized organizations have realized that it's really critical that they prioritize security. And as part of that, it is a comprehensive risk assessment and then a determination of what, given in some cases resource limitations, they might be able to do in terms of, at minimum, putting together a preparedness plan, doing some initiation and training with their employees around that. My colleague, Dr. Natalie Schwatka, would talk about shared leadership, and you can have distributed models around that as well, where employees engage in some, role differentiation and distinctions around the preparedness versus the response phase, but certainly help collectively to move the needle in terms of the organization's preparedness for a host of potential hazards. And I think that one of the reasons that we see, for example, this change in humanitarian organizations is, frankly, the liability issues became increasingly evident.
Right. Well, and I will say too, and Corey, I would love your response also. I imagine you work with a variety of divisions and departments, some, as you were saying, with higher risk and lower frequency than others, and vice versa. If this is an area that you want to dive a little bit deeper with HealthLinks on, we're happy to help and support. We have a total worker health assessment tool and disaster and emergency preparedness for organizations that don't necessarily bring that up frequently, is something that we've worked with a number of organizations on, and it does start with exactly what Sabina and Courtney are talking about. But Corey, how about you? How do you deal with different divisions or units within the city along these lines?
Mm-hmm. It definitely, it's a very interesting and an ongoing pursuit. So to put it in summary, if we're talking about trying to break through to get that level of safety, culture, progress, and emergency preparedness, I hate to say it, but just dropping one safety advisor into that department, it's not going to be entirely effective. The idea is that we want to be able to get the integration going so that safety management system is going to be built into that department itself, as opposed to one person trying to crack through. So in terms of the big seven, we're talking about being able to have the proper subject matter expertise and representation, which would be like a safety committee / ICS / NIMS. Then you've got your full hazard threat analysis, which includes your risk assessment. So they know not only what the hazards and threats they're facing are, but how it affects their particular mission and objectives, and then what they're expected to do about it, which would be your risk controls. And that's going to go back to the expectations, like it was discussed just a minute ago, as far as, are you expected to respond to this yourself, or are you expected to call in a responder, risk transfer versus risk control, et cetera. And then of course you have your communication for transparency and redundancy, and then your validation, and then the ongoing response / recovery. It's interesting as well, what we just discussed as far as integrating that into the organization itself, is if you have an organization that has like a mixed management model. So for example, like when I was in healthcare system, you've got your hospitals and then you've got your systems. So each hospital's got its divisions. You've got your emergency department, you've got your inpatient surgery, you've got your patient care units, et cetera. And then at the system level, they've got all those departments as well. So in terms of safety, if safety is not being managed at the individual hospital level because they're waiting for the system to manage it, and the system's not managing it because they're expecting the hospital to management, then it's not going to happen at all, and it just creates confusion and a lack of preparedness, which creates a lack of all kinds of other issues. So it's all about the integration, long story short. Thank you.
No, I appreciate that, and really integrating it into the core of the organization. I understand we're at the top of the hour. I do want to just, we have 1 minute for a question. I'm not sure I heard much about this idea of trust and trust in relationships and how important it is. Sabina, you brought up relationships, and in that, in brief, Dr. Welton Mitchell, do you have any comments about the importance of relationships and trust in this scenario? I know it's a big topic and we don't have much time, but and for those of you that need to hop off, we will put a link to the survey up, which will, for those of you that are leaving, close as you leave the meeting as well. But what do you want to say about trust's role in this, Dr. Welton Mitchell?
Thank you. I mean, I think we can look at the separate but adjacent construct of psychological safety, and that's really about the trust and the landscape within the organization. But I think to Sabina's point around not understanding how those relationships might unfold in a crisis. One of the things that I've been involved in, both as a participant and as a facilitator, is essentially simulated exercises. And I think that that's kind of a perfect opportunity to address some of those relational issues, as well as to practice some of the behaviors. And in some of those simulated crises, you do actually get a stress response.
Right.
For example, working with live actors in simulated environments where it feels quite, not entirely realistic, but somewhat realistic. So that's what I would say in brief about that. But I know there's much more that can be said about psychological safety.
Terrific. So once again, I want to thank you, Dr. Welton Mitchell, Sabina, and Corey for joining us today. Our next webinar is in May. It actually is a really great follow-up to this conversation. Each May for the last several years, we've had a conversation on the state of workplace mental health. May is Mental Health Awareness Month in North America. And so we'll be having a conversation with Dr. Alex Reed, who is team psychologist for the NBA champion Denver Nuggets, as well as a member of the UC Health team. Dr. Tashi Francis, who works at the Department of Veteran Affairs, and Bernie Wong, who works for Mindshare Partners. So for those of you, once again, thank you to our speakers and all of our participants today. Thank you for joining us. Please complete the feedback survey. The link will be in chat, and we will also send a link for everyone in follow-up emails. Hopefully it'll pop up as you close out today, but terrific launch to our 2024 webinar series. We're always so grateful for all the participation and for our speakers today. So thank you so much for joining us. Have a great afternoon or have a great day.
Thank you.